Hey, this is Dr. Madhvi again, and today we'll be discussing our first question, and it's the PPCM, or Presenting Complaints, Diagnostic Evaluation, Risk and Management. So, first is the definition. Look, whether you've been asked or not, if you give a brief introduction of the topic, like for an example, it's been asked that like the etiology of preterm labor, but you will write that what's preterm labor, and then you start with your etiology. Then it gives very good impression to the examiners that at least you know what the topic is about. Although I am not telling that you should write everything about the topic, what's not being even asked, but just a brief introduction of the topic only. The first is the definition. It's from the Williams. So it's development of the cardiac failure in the last month of the pregnancy or within 5 months after the delivery, in absence of the identifiable cause for the cardiac failure, and in the absence of recognizable heart disease prior to the last month of the pregnancy, and left ventricular systolic dysfunction demonstrated by the classical echocardiographic criteria. Depressed ejection fraction and fractional shortening along with the dilated left ventricle. So the presenting complaints are there are variable presenting complaints. It's from the 38th week of the pregnancy up to the 6 months. Most common is difficulty in breathing and lying down is orthopnea, pedal edema, cough, hemoptysis, fatigue, dizziness, palpitations, paroxysmal nocturnal dyspnea, and there will be no history of heart disease in this pregnancy. So now is the diagnosis. For the diagnosis, we'll start how like think like a clinician, that we are clinician. How we diagnose the case, like we take the history, we examine the patient, we send some level of investigation, we do some radiological investigation, and then we decide that it's whatever the disease is, like it's PPCM, right? So PPCM is a diagnosis of exclusion that we are supposed to mention that also in the paper. So first thing is the history, and it's compulsory to mention that there is no prior heart disease in this pregnancy, or there is no history of any heart disease prior. Then the symptoms, you can write. You don't have to write the symptoms again and again. Like we can also write that what we described above. This just I written because I had lots of time currently. So the symptoms are dyspnea, orthopnea, paroxysmal nocturnal dyspnea, pedal edema, unexplained cough, particularly when lying down, when which produces frothy pink sputum, palpitations, fatigue, chest pain, abdominal discomfort. On the examination, there is signs of heart failure, like sinus tachycardia, raised venous pressure, lung crepitations due to pulmonary congestion. It's diagnosis of exclusion. So what we'll do to exclude this? So we'll do initial evaluation, the history. Again, we'll start. It's just a short points like history, this past history of the same complaints or not, physical examination, if there any family history that I forgot to mention here, but I have written back then. Then electrocardiogram, we'll do a electrocardiogram, a basic electrocardiogram. It's not, there's no any definitive pattern for the PPCM, but there are patterns for the other heart diseases that we can rule out. Then blood reports, hemoglobin, C reactive protein, white cell count, natriuretic peptide, troponin D, blood gas analysis, except this anti-BNP is elevated in heart failure. Everything will be within normal limits. And echocardiography is very most important, that helps us to diagnose PPCM. There will be left ventricular ejection fraction less than 45%, left ventricular dilatation and enlargement, and the end diastolic dimension of the left ventricle will be 2.7 centimeter per meter square, and then there will be mode fractional shortening less than 30%. And I always make a flow chart, any this kind of diagram, just to summarize this workup. I do in almost every possible case, so that like you can see my handwriting, right? Why would examiner take this much effort to write the theory? To teach the theory. So I'll just summarize it for the examiner, so they know that I know but it's just that they don't have to read everything what I've written prior. I'm going to write that the theory part also, because I really need that what we call it, it's a page तो भरनी ही है वैसे. There will be shortness of breath towards the end of the pregnancy and postpartum period. Then what we'll do? We'll check for the natriuretic peptide and pro-BNP and anti-pro-BNP and echocardiography. If there is raised BNP or pro-BNP, or there will be ejection fraction is less than 45%, we'll involve the cardiologist and consider PPCM, and we'll evaluate for another cardiological diseases. And if it's in normal limit, this everything is in normal limit, then we'll exclude the PPCM, right? Then I'll rule out the differential diagnosis, that what if it's benign dysplasia of pregnancy, there would be no cough, right? It would be gradually non-set. What if it's arrhythmia, then there will be history of palpitations. What if it's embolism? If it's embolism, then it would be have to be in sudden onset, and there would be raised the dimer. And if it's because of asthma, HIV, hypertensive disorder, then there would be a prior history of the same. If it's idiopathic cardiac myopathy, then ventricular dilatation will be more, right? So this is supposed, if you can possibly mention this, so the examiner can know that you know better. Okay, then what are the risk factors? Risk factors are, like, I always write risk factors in short and sweetly, because they merely have 2 or 3 marks, right? So at least you will get 1 enough for sure. Okay, so this is maternal age, multifetal pregnancy, smoking, preeclampsia, prior history or family history of PPCM. Then the management. So every time I write management, I'll just make a checklist, or what I call is a goal or plan of management in my mind as a clinician also. So that's what I write in the paper only, that what I'll do, what I'll make a management plan, and I summarize it first. I first summarize how I'm gonna manage this patient, and then after I write that in detail. So if I'll lack of time, then examiner at least know that I know what I'm supposed to do, what I'll be going to do, so I don't miss anything, right? So I make a short list or summary of the management before I write in detail. That is it's a multidisciplinary approach, and I'll enroll that is pediatrician, neonatologist, cardiologist, etc. There will be abundance of heart failure drugs. What causes teratogenesis? Sorry, my mouth is like very dry. I'll avoid any teratogenic drug. I'll consider bromocriptine, because in its etiology we learn that it's caused by high prolactin level also. And then I'll be considering levosimendan for the cardiogenic shock. I'll transfer the patient to the tertiary care center for the better maternal and neonatal outcome, right? Then this is the flow chart. Again, maximum I try that I make flow charts or diagrams, so that I can just conclude it whatever I'm doing in short, so that examiner don't have to read everything, and they don't get irritated while reading my paper. So this is a flow chart. Look, I had this A4 paper, so it's in short and sweet and in 2 pages, but in DNB we get a supplementary. The supplementary what we get is very broad, right? So I'll be writing in this horizontal plane, and I'll make a diagram like this. Okay, this is what I do in exam, but it's because of lack of paper kind of supplementary, so I've written it like this in 2 parts. Okay, so if you want that I give you a full flow chart about this, particularly for this flow chart, you can just DM me, I'll send it to you. it's acute heart failure in pregnancy. I'll confirm diagnosis by ECG, 2D echo, X-ray. Then I'll do consider antenatal corticosteroid if the pregnancy is beyond 23 plus 6 weeks. Then I'll assess the failure of the severity. If it's acute failure, then I'll maintain optimal circulation, ventilation. Then I'll consider delivery. And if it's not, then if it's not that severe, then there would be antepartum management and the postpartum management according to severity, right? And it's another flow chart. It's in continuity, right? But I'm not able to show you this in continuity. Maybe I can share this diagram, flow chart, whatever we call, with you. It's in continuity in my mobile. I have access from where I have got this. I can share it with you. Just DM me if you don't understand this. And I'll maintain optimal oxygenation. I'll add inotropes. I'll consider levosimendan 1.1 microgram per kilogram per minute. I'll consider bromocriptine. I'll consider mechanical support if it's recovering or not. If it's recovering, then if it's not recovering, then I'll look for the transplantation. If it's weaning, then I'll manage like a stable case, right? Then again we are in this right part of the flow chart. On the right side is antepartum and postpartum, where the patient is stable and the severity is less. So what we do in antepartum, it will use MDT approach, right? Timing of the delivery between will balance between the deterioration of the maternal health and continuing pregnancy, and between the prematurity of the infant. If it's deteriorating maternal condition, will recommend delivery, preferably normal delivery, but it's very severe, then we have to do LACS urgently. Okay, then again we'll advance heart failure therapy. We'll give the advanced heart failure therapy. If the patient is stable, then what we'll do, we'll give heart failure therapy, hydralazine, nitrate, beta blocker, consider diuretic. We'll plan the delivery. We'll prefer the vaginal route. If we are delivering the patient, then what we'll look for, what we will take care intrapartum. Then we'll give left lateral position to the mother. We'll do input-output monitoring. We'll give regional anesthesia to avoid tachycardia and preload to the patient. We'll cut short the second stage. We'll do instrumental delivery. Okay. Then what we'll do for the third stage, to prevent PPH, we cannot give methergine, so we'll give low dose oxytocin or misoprostol or carboprost. And for the breastfeeding, we can breastfeed the patient. It's if the patient stable. And what's the prognosis? We are supposed to write the prognosis like 50 to 80% people are recovering, and the 10% gets dead. So mortality is also high in PPCM. So that's also we have to write. And like we have managed in this pregnancy, but we are supposed to think about the subsequent pregnancy also. If you can write about the subsequent pregnancy, then it would be plus point. But if you don't have time, just avoid this point, and you just write another question, answer for the another question, right? Only consider the subsequent pregnancy management if you have enough time left. So what I'll do, I'll check for the ejection fraction before the pregnancy. If it's less than 25%, then pregnancy is contraindication. We'll do the preconceptional counseling. We'll give the patient about the advice about the contraception, contraceptive counseling. And if it's around 35 to 45%, then we'll get anticoagulants, and we'll manage like that only. And it's just we are supposed to write this in brief, because it's not asked the question. It's not the question that had asked that what we'll do in subsequent pregnancy. So we'll just brief about it, and we'll also brief about a little bit about the postpartum contraception. That we cannot give the combined hormonal drugs that increases the risk of DVT. Already patient is in heart failure. That's we are supposed to write about. We cannot give IUCDs, copper IUCDs, because it will increase the risk of menorrhagia and subsequent cardiac load. So we'll give advice for the condoms, barrier method, and the Mirena, and the progesterone only pills at extra. Okay, so we are here. We are done for the answer of the PPCM. What risk factors, diagnosis, and management. But if you want scan copy of this answer, just DM me because my handwriting is not that good. So I have explained everything in detail what we are how we are supposed to write the answer. Okay. So all the best and tell me if you know any better way to write this answer. I'll also consider it. Thank you and bye bye.